So I want to start by saying that cancer-related fatigue and brain fog cannot go one without the other, okay? So it's tightly linked, and I'm going to try to explain why I can't separate both to try and explain what brain fog is. So it is a clinical phenomenon that's just starting to be formally researched and looked into. It all starts by a patient coming in and describing what they're going through, and doctors and healthcare professionals taking notes and wondering what it is. But it's here, it's real, and I'm going to try to explain what are the two perspectives we're trying to use to explain it. So what is it? It is an unintended damage to the central nervous system induced by cytotoxic drugs. So whatever you have in the chemotherapy that are used to treat all types of cancer. And so it's not necessarily deficits that are related to brain cancers, it's different. So this is called collateral toxicity. We don't know yet which particular agents are responsible for brain fog, but we start to see that some chemotherapy complex tend to trigger more of the cognitive deficits. So it is an acute or long-term, residual and sometimes lingering neuropsychological impairment.
What does this mean, lingering?
It means lingering, ça persiste. Mm-hmm. Again, chemobrain was unacknowledged to the medical community until recent years. Anywhere between 4 to 75% of people with cancer experience brain fog. What is it? It's really mild impairments, but that could really affect significantly your ability to function daily, to work, and to do higher complex tasks.
It's not mild. It's often not mild. No.
When I say mild, is that we're not looking at major deficits such as exactly. I'll get to that.
I have just a little question because you mentioned non-CNS tumors. What if it's a CNS tumor?
You could have it too. You could have it too. It's just more complex when it comes to brain tumors. Yeah.
Brain lymphoma.
So one of the agents we try to identify is cyclophosphamide, or the chemotherapy called idralazine, Mycet, Taxotere, and those chemos are very famous and used to treat most of the cancers. So it's not just affecting people with leukemia or lymphoma, but a wide range of cancers. So in a nutshell, what it does is that agent will produce an inflammatory response, and when the cancer cell is being destroyed by the chemo, and that it will release cytokine, and that will go through the blood-brain barrier into your brain. So it's going to lodge itself in the hippocampus or different parts of the cortex. It will cause oxidative stress, so free radicals in your brain. And that's the key part, mitochondrial dysfunction, so the process that's responsible to create energy for cells. So you see the relationship between brain fog and fatigue there. And consequently will impair the working memory. So working memory is a combination of memory, attention, concentration, focus, and processing. Okay.
That's me. You just described me.
Perspective number 2, as suggested by Ferguson, looks more at it from the perspective, again, of fatigue. So during times of heightened stress and anxiety, the brain is trying to redirect blood and oxygen to the critical areas that need help. So the blood flow into the thinking area, the brain, are reduced. This leads to decreased ability to process information into the long-term memory. So processing information in long-term memory, what it means, it's basically learning. So learning, processing, problem solving, trying to, go through a conversation with someone. We'll get to really what it looks like from your perspective. Brain fog is really the go-to all symptom. Okay, there's many other causes that are suggested to explain why people have it, but it could be caused by hormone therapy, so menopause-like symptoms, or immunotherapy that will cause damage to the DNA or the telomere length, so associated with the aging process. Radiotherapy, stem cell transplant, and the heavy chemotherapy patient will go through. The effect of the post-operative recovery phase of surgery, that's a complex one. Fatigue, we talked about it. Chronic sleep disturbances directly related to brain function, so affecting performance and behavioral patterns. Nutritional deficiency, and anxiety and depression, so the cognitive complaints of subjective nature. What I mean by that is sometimes patients come to me and they try to describe what they're going through, and it's so complex. So first of all, they start by telling me that I'm fatigued, but it's physical, it's emotional, it's psychological, it's mental, it's everything. And then I can't focus, I feel lethargic. So they use terms more, instead of using terms like I can't think, or they will say I feel lethargic, I feel like a lack of drive, a lack of motivation, can't focus. So subjective nature in the sense that it's also linked with an emotional experience they're going through. Chronic pain medication use, that could also contribute to brain fog. So what are your symptoms? Feeling of mental fogginess. Some patients tell me it feels like I've drank 2 beers. This is what it feels like. It's as if yes.
I'd love to see the second point, forgetting names, faces of people.
I'm getting there, yeah. So feeling of mental fogginess, forgetting names, faces of people.
I insist on this. I completely lost the ability to recognize a face. It's really very undamaging socially because you speak to a person and second after you don't recognize that you spoke to them.
You will see yourself in this list of symptoms, yes.
Recognize yourself.
Difficulty recalling things when really trying hard to do so. Forgetting details of written information, so you're reading a book and you forget the plot summary or the names of the characters. Difficulty staying alert, paying attention. Difficulty sometimes making sense when trying to explain something. Some people have reported that. Difficulty following what people are saying, being usually disorganized, difficulty planning, going through a task, completing a task, difficulty learning, being less efficient throughout a task. And what I want to mention is baseline function. People that had, very complex jobs, mentally demanding jobs, those are the ones who will notice it even more because they go from high-level functioning to having difficulty in everyday tasks. What patients tell me is that, first of all, who heard about brain fog before they started chemotherapy? Nobody.
If they told me about it, I don't remember because I had brain fog.
Good point.
There's a lot of stuff I don't remember.
How many of you have had a doctor who've actually sat down and explained what it could be and what it might look like? That's right. So no one.
There's also a question of aging as well.
Yes, and I think I've mentioned that. Yeah. No one told me I could get cognitive deficits after chemo. When will it go away? How long before I see any improvements? Is it dementia? Is it aging? What is it?
Do you have answers to those?
Yes. Maybe I want to go through the presentation and then we can use that in the discussion. So my focus, as I started talking earlier in occupational therapy, is really looking at complex activities that patients need to do during the day. So a greater focus on work or school-related tasks, because I have young patients too. higher, more complex tasks on a day-to-day basis, such as meal preparation. It's considered a complex task. Financial management, social conversations. I try to assess, and help the patient go through the process of returning to work, looking at cognitive performance, what they need to be able to do at work. What are the barriers to them being able to do this efficiently? Sometimes we even look at driving abilities, because that could be affected by brain fog. Some people have a really hard time with social, get frustrated by the fact that social interaction becomes more difficult. So we look at life roles such as parenting, being a public speaker, you name it. People have roles and they are important to them. So looking at cancer-related fatigue again and the impact it has directly on attention and concentration. Some of my patients even have a hard time going through therapy and carrying on a home program, or coming home and trying to implement the strategies I try to teach them. So I even try to work there. The impact it has on current leisure activities, what they used to do that we'd like to go back to, and why it's not working. So just to finish off, it's a lot of education. There are many compensatory strategies for memory and attention problems, but I start by saying that every person is different and is in a different environment. So it's really person-specific to what exactly their goals are. Teaching energy conservation and energy optimization strategies, again, to enhance concentration and attention, and teach them to be more assertive and to be able to set boundaries with people, because people don't, as we were mentioning, I use the word mild, but for you it's a major change, and it's not visible to others. So how do you communicate that to people when people don't see it?
You just try to hide it, not to communicate.
You try to normalize it as much as possible. I suggest this book, if anyone heard of it already.
Right after chemo, somebody recommended it, but I haven't got it yet.
This is an excellent book. I am not, in relationship with any of the other authors. I don't know them, but I've read this book, and it's from the perspective of patients, basically. So it's really reassuring for patients to read maybe just parts of the book, not the whole book. But 2 quotes here. Task completion is where I am most affected cognitively. It's as if the follow-through feature has been removed from my brain. I would struggle with spelling words I had known forever. I would forget names, places, and conversations. Yes.